take a look at coronary steal syndrome. Now, in order for you to understand this, this once again comes back to functional anatomy of the heart. Let me set this up for you. All right, first and foremost, I want you to come down and take a look at where it says coronary vasculature. You see that? Okay. Now, that is the lumen, and I want you to go ahead and call this the left ventricular wall. Are you with me so far? Okay? So that is the left ventricular wall. And where it says coronary vasculature, I need you to think of that as being the lumen of your left ventricle. All right? That's a chamber. So that would be the endocardium. Endocardium, right? Now, as we move superficial, are you with me? Superficial. We're moving towards the surface. So we're moving through the myocardium. You see where it says myocardium? And then we're getting to the pericardium. All right, now, is this picture perfectly clear to you? It should be. Next, you see where it says pericardial cavity? What was it called again? When you had sudden rupture of that ventricular wall, especially when you had a macrophage degradation. It's called a left ventricular pseudoaneurysm. And what are you worried about? You're worried about rupture and what's that called when you have rapid accumulation of fluid in your pericardial cavity? It's called pericardial tamponade. I said that fast because we already covered that. Okay, now, in order for you to understand further, there are a couple things here that are ridiculously important. Take a look at that coronary artery, all right? You see that coronary artery, and that is then supplying your surface of the heart. In other words, closer to the pericardium. As you move deeper down through the myocardium and then eventually to the subendocardium, understand that you are now branching into your arterioles, okay? Now, the reason that this is all important to you clinically is the fact that say that you had a coronary artery, massive occlusion in which you had a MI, okay? There was a myocardial infarction taking place of the coronary artery. I am purposely emphasizing artery. You tell me, is that entire wall underneath the coronary artery being draped and undergoing infarction? Or is it only the subendocardial portion? Now, the coronary artery is supplying blood down through the branches and tributaries. So it only makes sense that if there was coronary artery occlusion completely and the patient had myocardial infarction, that entire wall, what's wall mean? Mural, huh? There you go. Transmural type of myocardial infarction would be a myocardial infarction or occlusion taking place in your coronary artery. Why is that so important to you? Because you are expected to know on your EKG the type of ST change that you would find with the transmural type of myocardial infarction. And you will tell me what kind. ST elevation or non-ST elevation. ST elevation with transmural type of infarction. Good? Let's take a look at arterioles. You see that? Say that you had a myocardial infarction of an arteriole. And it's way down by where it says coronary vasculature. And so if you had an arteriolar type of occlusion, are you going to suffer myocardial infarction? Of course you are. But then what would you call this? Not transmural, but subendocardial myocardial infarction. Are we clear? How can you tell the difference? Well, first and foremost, they're both MIs. Are you going to find cardiac enzymes? Do not let that question fool you. Of course you are. It's a myocardial infarction. What's the gold standard? One more time. I am the most amazing, medical student. Because you know it's troponin I, right? So in both instances, you will find a gold standard of cardiac enzyme being elevated, granted. But then how can you tell the difference between transmural coronary artery occlusion versus your arteriole type of subendocardial myocardial infarction? Non-STEMI, which is an ST depression type of issue, would be with your subendocardial. Coronary artery, transmural, would be STEMI. We'll talk about this again, but I need you to visualize the anatomy here so that you're clearly seeing as to when you're having a drape type of infarction versus subendocardial. Next, when we get into coronary steal syndrome, well, there are times when you might want to use certain drugs, okay, in which you might then cause coronary arteries to dilate, okay? Now, what is that going to do? I'll quickly walk you through this, and then we're good to go. And then on the next couple of slides, then the information is all here. I need you to listen to me right now. Listen first, then see. Now, you give a drug that is going to cause immediate vasodilation. And why would you want to do this in a patient? Well, your patient has something like stable angina. And with stable angina, what do you know about the atherosclerotic plaque? Rather minimal, and the pain occurred when? During exertion. Now, you tell me. When you exercise from physiology, what kind of effect does it then have on your blood vessels? When you have exercise, obviously, when you exercise, all of your muscles require greater amounts of oxygen. So just by sheer common sense, what then happens to your blood vessels? They're going to dilate. They have to. Why in the world would you want your blood vessels to constrict when you're exercising? That wouldn't mean that you're supplying more oxygen. Is that clear? But Dr. Raj, I thought exercise meant sympathetic. Yeah, of course it does. I'm not saying that it doesn't. But when you exercise, your body knows that it cannot be strictly sympathetic activity on your blood vessels because that would cause vasoconstriction and it would defeat the purpose of supplying oxygen to your skeletal muscle or your heart muscle. So then you have certain metabolites. What are those metabolites called? ATP stands for adenosine triphosphate. Adenosine. What kind of effect does adenosine have on your blood vessels? Vasodilate. What about lactic acid? Vasodilate. What about carbon dioxide? Where is carbon dioxide coming from? What happens to amount of carbon dioxide production with exercise? Increase, doesn't it? Of course it does. You have more glycolysis, more T-phase cycle from biochemistry, releasing more carbon dioxide. All of those are vasodilatory metabolites on your blood vessels. Is that clear? So my point is this. When you induce stress, let's say that it's going to be physical stress with the patient with stable angina, you're trying to then create an area where you have increased coronary artery dilation, okay? So that area where it's undergoing your occlusion feels the pain. Are you feeling the pain right now? I hope not. If not, go to the doctor right now. But point is this. If the patient is feeling pain during exercise, then you know and find ST depression and such. You know your patient has stable angina. Can you mimic this medically? Of course you can. Exactly what we just did. Instead of exercise, why not replace it with a vasodilator, such as adenosine or its analog? That's exactly what you want to do. And when you do so, you cause your coronary artery to then dilate. It will then steal the blood from the area where it is stenosed to your coronary artery, which is now open. And what's your patient going to feel? Pain. Clear? Now, other drugs that you might want to use, including dobutamine as well, in which it's a chemical stress test. But understand the concept of coronary steal syndrome, please. Here you find your two different types of myocardial infarction. You find your subendocardium, which would be arteriolar type of MI, versus transmural. What kind of coronary artery? Arterial. It would be a coronary artery. Transmural.